that's where you wind up being comatose and with cardiac arrhythmias and usually death. Interesting, if you have a myocardial infarction right now, in the past probably 8 years, one of the treatments for post-arrest is therapeutic hypothermia. If you're unconscious, they will take a day to cool you down and keep you at that cool temperature for 24 hours, and then take a day to re-warm you. And the heart hospital in the state takes you all the way down to 32 degrees centigrade. 32 centigrade is a core body temperature of 89 degrees. That is cold. Okay? Of course, you're not conscious when this is happening. You can't be conscious. It's too painful. All right. Okay, so interesting thing about hypothermia is that you get certain shifts of electrolytes. Glucose is typical. Hypoglycemia, hypophosphatemia, hypomagnesemia are all characteristics of hypothermia, not hyper, but specific to hypothermia. One thing you ought to keep in mind, though, is that sodium and potassium imbalances in hypothermia don't make sense. They do make sense in hyperthermia related to sweating. They don't make sense in hypothermia. They can be up, down, or normal. And you should be aware that the temperature has a small and really insignificant impact on blood pH. If you look at the oxygen hemoglobin dissociation curve, if you look at the effects of temperature on pH, it does matter. But you see there it's like 0.015 for every 1 degree C or 1.5 degrees Fahrenheit, and it really doesn't make that much of a difference. Who really cares if your pH is 7.3 or 7.315? It really doesn't matter. One thing, though, it is characteristic of hypothermia is the presence of this R prime wave or Osborn wave, or also called J wave, on an EKG. It's a very characteristic thing that shows up in hypothermia. There are other types of arrhythmias like AFib and prolongation of the PR or ST segment, but the J wave is, or Osborn wave, is the telltale sign for significant hypothermia. Complications of hypothermia, there are a whole lot. And one of the bad things about hypothermia is that one of the worst things that can happen is when you try to correct it by rewarming. That's when you get all sorts of electrolyte shifts, and you can wind up with an arrhythmia, even VFib, during the rewarming phase. If they go into VFib, you have to deal with the VFib. Now, to rewarm somebody, there are different approaches. You can rewarm through every orifice, essentially. First of all, you want to get them on a humidified oxygenation mask. Now, you know that you can hook the tubing up to the wall and it blows air in. There's also a mechanism where the tubing from the oxygen goes into a water bath, and from the water bath, the oxygen goes to you. So it's humidified air. You can heat that bath so that you inspire warm air. You also can go through and put warm IV fluid, put a IV bag literally in the microwave for a few seconds to warm it up. I mean, you don't want to get it boiling, but you want to get it warm to touch. Remember, your temperature right now is 98 degrees. Can you imagine how hot this room would be if it was 98 degrees? Right? So that bag can be pretty warm, and it's still less than 98 degrees. You can put an NG tube down and instill warm saline into the intestines. And finally, you can put a needle into the peritoneum and inject through a bag warm fluid that will circulate amongst the intestines. And because the intestines are so vascularized and the vessels are right there on the surface, that will speed up warming incredibly. But it usually requires somebody with the cojones to stick a needle in the peritoneal cavity for that purpose. The other mechanisms are easy to do. Now, you can also go really radical and stick a needle into the chest cavity to warm the heart and lungs up, but that's, again, way beyond what you're going to do in the ER. You can put aortic venous shunt. Let me back up. You can take. There are different machines in the hospital that are used to circulate blood outside of the body. You use them in cardiac surgery. You can use them in the ER. And these are called extracorporeal devices. And you can do that with rewarming. So you circulate the blood through this machine to warm it directly. Again, the complications of rewarming include everything up to VFib. Don't forget, though, that if you're treating hypothermia, it's like everybody in the ER. It's like what Lovelace said yesterday. Take the clothes off of them. You examine the whole patient. You don't want to miss in this 88-year-old who was found out on the front yard and had been out there since the paper was delivered at 5:30 a.m. and she's hypothermic. You don't want to miss the fact that she's in her front yard on the ground because she broke her hip. So you need to do a thorough assessment for any secondary conditions there. Thiamine, D50, and Narcan, that's your coma cocktail. Essentially what you want to give them right up front. There you go. Now, cold extremes. We're talking about not hypothermia, but extreme cold temperature on your skin exposure directly. It can survive pretty well down to 25 degrees or less than 25 degrees Celsius for short periods of time, but you certainly don't want to expose it to that for longer periods of time because it will become, you'll result in freezing of the tissues and subsequent damage related to that, direct freeze injury. There you go, actual freezing. Chilblains is an inflammatory process that is it's a vascular inflammatory process that occurs in not necessarily freezing tissues, but prolonged exposure to cold. If you've been outside in the wintertime, you've been playing around, you know, when you were younger, you were outside all day long in the snow, and the gloves and stuff got wet, and you had a great time, you were out there all day long. You did not suffer frostbite, but you did suffer enough tissue damage to produce that stinging, burning, redness sensation in your toes and in your fingers. That's chilblains. Okay, it's a reversible process. It usually recovers quite nicely just rewarming. The thing you don't want to do with frostbite or chilblains or trench foot is to rub it. Okay? No rubbing. Frostbite, on the other hand, is tissue destruction. That is, to an extent, reversible. And the problem with frostbite is it can look horrible, and then if you give it enough time, the tissues can recover. Okay? So I'll go into that in just a second. The thing about frostbite is that it will be, the skin is blanched, it's hard to touch, it can appear dark, almost gangrenous, but and leathery. It can present a whole number of ways, but what you're trying to prevent is gangrene. What you're trying to prevent is gangrene. The bad part about this is like a third-degree burn. The difference between a second and a third-degree burn is a second-degree burn, you can feel pain. So if I take a needle and touch a second-degree burn, they feel pain. A third-degree burn, you burn the nerve endings and they can't feel pain. That's the same thing with true frostbite, they can't feel pain. Now if you look at frostbite, it can take it mostly is going to affect exposed hanging out parts, toes, and the ear here is infected. Now I had a patient one time when I was a student. He was a homeless guy that was walking across western Kansas in the wintertime in the snow, and they found him and brought him in, and he'd been out there for days, and his toes looked like that. And we put him in the hospital and treated his toes, that we'll talk about in just a second. And over the course of about 2 weeks, he completely recovered from that. And his toes were just that black. So one of the treatments for frostbite is to delay amputation until you're confident that you can identify the tissue that won't come back. All right? Rewarming produces all of these different signs and symptoms, and these are intuitive. There's nothing surprising about these things. Eventually, if it doesn't come back, you're going to wind up with gangrene and an amputation. The different treatments for frostbite here, you got to get anything wet off of them, and you rewarm the area with no rubbing. If there are open wounds, like in this, let's see, this right here, up at the top of that, and probably around in here, if there are open wounds, you want to use antibiotic ointments like triple antibiotics, Neosporin type stuff. If they're not open wounds, but the skin is just damaged, to prevent infection from the tissue, Silvadene cream is a very good soothing cream. You have to make sure they're not allergic to sulfa, though, with Silvadene cream. Okay. Silvadene cream is also used by a lot of people in burns, in sunburns, bad sunburns. Aloe is good as a moisturizer. Okay. Make sure that their pain is taken care of, because as it rewarms, it is excruciatingly painful. To the point of, like in the guy with the toes there, possibly IV analgesics. On top of that, as with any skin damage, you want to make sure they're covered by tetanus. And here's the thing here, you delay surgery as long as possible. When you're convinced that this is all you're going to get back, then you're going to have to go for amputation. Immersion syndromes, these things also called trench foot. This is when your feet are in wet shoes or boots for prolonged periods of time, day in and day out. It was first recognized back in Napoleon's day, but really came to light or got the name trench foot in World War I, where trench warfare between the two powers kept people in their feet submerged. And they didn't have the nice waterproof shoes back then. It was also a big problem in Vietnam because of the frequent rains and the jungle streams. And of course, the prevention of trench foot is to keep the feet aired out and dry. That's it. One of the things that, in terms of development of trench foot, is hyperemia. The skin becomes reddened. And from that reddened skin, that's when you'll start getting tissue breakdown, blisters, open sores, and this can lead to amputation as well, as it did in World War I quite a bit. If the open sores become infected with fungi like tinea, then that's called jungle rot. And as you can imagine, it smells not lovely. Treatment of trench foot is don't let it occur to start with, but if it does, you have to get them off their feet. You have to get them dry for prolonged periods of time, get them elevated, and let them essentially dry out and re-epithelialize. Trench foot is not really that big of an issue in today's military. One is because of the theaters the U.S. is operating in. It's not the same as it was in the World War I, Korean, or Vietnam days. Is there any questions about hypothermia? Hyperthermia, there are different levels of hyperthermia, from edema to heat stroke. The people who are predisposed to hyperthermic conditions, again, those particularly that live in my neighborhood down in Brook and Cove at Eufaula in August, and they take their pontoon boats over to Alligator Cove, and they spend all day over there drinking an enormous amount of beer with it 400 degrees outside, and they're lying prostrate on the mud beach. I don't get it, but that's what they do every day. So there's a Baptist church right across the street from where our house is. It's called the Heaven Bound Free Will Baptist Church. I'm thinking about writing a country song about the guy on the pontoon boat, you know, the 30-something-year-old guy who's obviously divorced with 6 kids. He's still living with his mother, who makes him go to the Heaven Bound Free Will Baptist Church every Sunday. So I almost got a pen, so give me a little time. Any other questions about that? Excess, that usually results in heat-related injuries. Heat edema has to do with people who are out in the sun all day, or just not taking care of themselves, out gardening or whatever. They tend to retain heat or retain fluid, and they wind up with swollen feet, rings that won't come off. It's just an inflammatory process that occurs with just overexertion. If you're out there mowing the grass down at the lake on Saturday when it's 98 degrees outside, or walking the dog, you know, that's just, you don't want to be doing that. So you can tell it's pretty easy to enter this phase, but it's pretty easy to treat it. You just, you cool them off and you rest them, and that usually takes care of things. Syncope is, of course, what it says. Being out in the sun all day, mowing the grass with a push mower, not a riding lawnmower, just, again, overexertion. It's a temporary thing that can be taken care of with just a little bit of rest, lying down, cool compresses, rehydration, and that usually takes care of heat syncope. When you get into heat cramps, this is heat syncope. Heat syncope, these are not one worse than the other, necessarily. Edema is probably the mildest form. Syncope is the next mildest form. And then you get into heat stroke. But heat cramps can occur anywhere along there. And what you're dealing with heat cramps is really an electrolyte imbalance. Anybody ever suffered these things? They can be pretty painful, especially when they hit your abdominal muscles, like you can't straighten up, they're in spasm so bad. To treat these things right here, you want to get rehydrated. You may need to if they're in your ER, of course, IV with normal saline. And I think Dr. Lovelace pointed out to you right here, that's where he had normal saline. When you're talking about somebody that's dehydrated, that's what you rehydrate them with, is normal saline. All right? You can use ringers, but normal saline is easy, cheap, fast, and everybody has it. All right? Heat exhaustion is, once you get to heat exhaustion, now you're getting more serious. In heat exhaustion, you have actual hyponatremia. That hyponatremia is due to excess sweating compounded by excess rehydration with water and not with a sodium-containing solution. So sodium is going to go down. These are the symptoms related to it up there. So sweat without salt intake. Lovelace was telling me, he mentioned his daughter Emily yesterday going to the ER with hyponatremia, and we were talking about it. I said, how did she wind up with hyponatremia? He said, well, she goes to an adult daycare. The syndrome he said she had is Prader-Willi. I don't know if you called that. He said it kind of that, Prader-Willi. You need to look it up if you don't know what it is. But one of the problems with Prader-Willi syndrome is they eat everything. He has locks on his cabinets in his kitchen because she will eat everything, drink everything. So she went to this adult daycare, and when she doesn't get it, she gets mad. And she's not a little person, but she was drinking. He picked her up one day from daycare, and she consumed 5 2-liter bottles of Coke. 5 2-liter bottles of Coke in one day. So he went ballistic on the daycare people. So he said, no more Coke. So the next day, what did she do? She drank 5 2-liter things of water. What do you think that does to sodium? That's when he took her to the ER. He mentioned yesterday she had a sodium of like 115 or something like that. Well, that was why. It was delusional. That's the same thing can happen here. If you're going to rehydrate, you need to rehydrate with sodium. I don't know if they still have in athletics. When I was in high school, playing football, you weighed before you went out to practice. You weighed when you came back in, and the differential determined how many salt tablets you got. Do they still do that?
No.
Yeah, see, back in those days, they didn't give you breaks to drink. So now, of course, during you have free water or free sports drinks at the practice all the time. They don't do like the old days.
We drink pickle juice too.
Yeah.
Yeah, some people can drink pickle juice, which is not a real good thing because it's got like acid in it, which is not a good thing to be concentrating. I had a patient come in one time that drank a whole bottle of pickle juice, and not only was he throwing up everywhere, if your renal function is okay, you're probably going to take care of that, but it's really not a good thing to drink.
Our trainers that have salt packets in the kit too.
So what?
With our trainers that have salt packets in the kit in case
Yeah.
anybody started getting symptomatic.
Yeah, the 10K All Sport Gatorade, that really needs to be made available freely. But part of our practice back in the old days was, to make you tougher, they wouldn't give you water breaks, and it was pretty bad. We used to sneak off in junior high school. There was a woods behind us. These muscadine grapes grew wild. We would go and get a handful of these muscadine grapes just for the liquid. Curtis Young was the football coach. That man was the devil. when we were in the ninth grade, so we were seventh, eighth, ninth grade, and then 10th, 11th, and 12th grade. Our ninth grade, so we were the top of our junior high school, we were unbeaten and unscored on the entire season. But Curtis Young was such an evil man that that was the best summer of my life, that bastard wasn't gonna, I was done with him. That freaking summer, he got transferred to the high school. 3 more years. 3 more years. Okay, oh, the salt tablets, here are the salt tablets. Salt. It says right here in hyponatremia to use hypertonic saline. Never, ever, ever do this unless the patient is in an ICU and you're not the one doing it. Make sure it's an internal medicine, a nephrologist, or somebody like that doing it. The use of 3% saline to increase serum sodium is, it makes your palms swell and you can gorp somebody out. So that's why, if you have a hyponatremia, give them normal saline and restrict water. That's how you get the sodium out. Okay. Heat stroke, let's talk about that for a minute. Now you're getting into the most serious form here, where you have alterations in metastasis. The core temperature in heat stroke will go up and above 105, so the oral temperature is 104. That's pretty bad. Rhabdomyolysis is the thing with heat stroke, not hypothermia, not the other heat conditions, but heat stroke can produce actual breakdown of muscle and rhabdo. Rhabdo, of course, what's the problem with rhabdomyolysis? Kidney failure, yeah. It clogs up the kidneys and can kill your kidneys. Obviously, the death from all of these different reasons is a potential. These people are predisposed to heat stroke. On the drug side, it's mostly ecstasy, where you're, I don't know if you guys are still going to raves. Brad, you still going to raves?
Yes, sir.
Okay, so being up all night, partying on, rolling on E. That's what, rolling on E. What's the thing about ecstasy? What's the unique thing about ecstasy? Not that you pump everything out there, but or have sex with everything. What is it that's specific to a side effect of ecstasy?
I don't know.
What?
You get really, really hot.
Really hot, yeah. You get hot because you don't perceive that you are hot. There's something specific to ecstasy. Come on.
That's what you get intense.
Huh?
Someone who is your sex drive?
No, that's a side effect of ecstasy. That's the effect. That's not a side effect. That's the effect. Ask Brad. You're sitting right next to him. Bruxism. They can't. When you know, Taylor. When you go to they give you suckers to keep your mouth because of they're grinding the teeth. Bruxism. Come on, you know that. Don't say you don't. Bruxism. Have you ever heard of that?
No.
Y'all need to get out more often. Y'all need to do more recreational pharmaceuticals. Yeah, Cooley sells it, so you can.
Straight from Nigeria.
Straight from Nigeria.
That good stuff.
You got the good stuff. Signs and symptoms of heat stroke. You've got quite a few symptoms related to heat stroke here. You got to cool them down quick, and more signs and symptoms here. They can wind up once these things are cascade. Once they start, it's hard to stop them. So you've got to get on them aggressively to cool them down. And the cascade can lead to DIC. Somewhere up there is DIC. So that's why it's important to cool them down quickly. a lot of lab you can order here. The machine oil urine, the tea color or brownish urine here is due to the rhabdo, not to bilirubin, but due to rhabdomyolysis. There are certain things that you need to do with heat stroke. Is one, and moms like to do this too for little kids who are running a fever, is to give them an alcohol sponge bath. You don't want to do that to little kids, and you don't want to do that with anybody having a heat stroke, because the alcohol can be absorbed through the skin and cause problems related to that. So what you want to do is you want to use a cooling blanket, which is in the OR and ER, they have two types of blankets. They're water circulated blankets, one for cool, one's for heat. So you want to use a cooling blanket. You also want to take ice packs, crunch them so that they're cool. You want to put an ice pack in each axilla. You want to put it in their groin, and you want to put it around their neck here. This is the same thing you want to do with a kid having a febrile seizure. You want to get them cooled down as quickly as possible. One thing about heat stroke, though, is that it really doesn't respond that well to aspirin or Tylenol, because those drugs work by inhibiting prostaglandin synthetase, and it's a central action. This is a core action. Your core is overheated. It is not a reset of your temperature regulator in the hypothalamus. You got to respond to the core. Going back one, to control the shivering, once you're getting them under control, Thorazine is a good drug to settle them down so that they can tolerate the treatment here. I would definitely get a Foley in them. Okay. Mannitol. The use of mannitol here is for not only diuresis, but to control cerebral edema associated with heat stroke. By this point, they need to be in an ICU. Way before this point, they need to be in an ICU. Do you need to take a break? There were a couple people going up and down. You okay? Keep going. Okay, drowning. Drowning occurs really in a couple of different fashions. One is by asphyxiation. You have laryngeal spasm, so you wind up drowning without the presence of fluid being aspirated into your lungs. The other type of drowning is, of course, you aspirate the fluid. When the ME's office is looking at drowning victims, they'll often determine whether or not you were dead before or after you entered the water by the presence of fluid, keeping in mind, though, that this also, no fluid in the lungs, deep in the lungs, is a possibility. All right. Alcohol and drugs, here again, we've got as prime players. Now, here, we're going to go here in the sequence here of drowning in just a second, but remember that the sequence of drowning is prolonged in cold water. We talked about the mammalian diving reflex yesterday for some time, and so that comes into play again today. The drowning sequence is here. Obviously, you're going to start with hypoxemia, laryngospasm with or without fluid aspiration that results in eventually poor gas exchange and death. Drowning can take anywhere from a few minutes to hours if you're in ice cold water. There is a difference between drowning in not only cold water versus warm water, but fresh water versus salt water. The end result is not significantly different. You're still drowned. However, there are physiologic changes that have to do with the hypertonicity of salt water over fresh water in terms of ability to dissolve surfactant in the lungs, the electrolyte exchanges in the alveoli. But again, really the end result is you're still dead. Near drowning in salt water produces more complications than near drowning in fresh water, although fresh water is still is pretty significant because of these different criteria. Little clinical significance is what I just said, and so not only do you disrupt the endothelium, the surfactant, which is required to keep the alveoli expanded, is washed away. Therefore, you wind up with atelectasis throughout. Preceding drowning, again, the alcohol is really probably the number one cause. Extreme fatigue, being out there in the lake all day is one reason. There was a drowning down in Eufaula a couple of weeks ago. We were down there. This guy had his grandchild on the wave runner. Neither one of them could swim. Neither one of them had on a life jacket. And the guy was, they both fell off the wave runner. They hit something, fell off out in the open water. He was holding his granddaughter up. Somebody came up and got the granddaughter, but he went down and stayed down until the next day. So stupidity plays a big role, along with alcoholism, in most of the drownings in Oklahoma. Of course, you can't rule out an organic cause like the patient had an MI or a seizure. That wasn't this guy's case. Okay? Stinging by aquatic animals if you're allergic to them, or eaten by aquatic animals if you're allergic to them, is another thing. If you go scuba diving down in Grand Cayman, they have a dolphin down there that's wow. If this dolphin shows up, everybody has to get out of the water because dolphins like to play, and they're worried about the dolphin playing and grabbing you and taking you down to 200 feet. So you don't want to do that. Intentional hyperventilation, it just kills me. These guys are, okay, I'm going to go down. I've had a little bit to drink. I'm going to go down, touch the bottom. You hyperventilate so you can stay down longer. You get down on the bottom and you don't come back up. Don't do that. Near drowning has to do with aspiration type pneumonias or damage to the lungs. It usually takes anywhere from hours to a day or so before your lungs just can't keep up with it. And here's the thing about this, is when you wind up with pulmonary edema, when I say pink frothy sputum, what are you going to say? Let me try it again. When I say pink frothy sputum, what are you going to say? You know, you might see that in multiple choice format later on. Okay? Pink frothy sputum is pathognomonic for pulmonary edema. Okay? Bloody sputum is pathognomonic for what? Not pulmonary edema. That's pink frothy sputum. Okay. Lab findings in drowning, you know, most of it have to do with hypoxemia. Thing that you want to keep in mind here is that what you're going to see on x-ray, you get an x-ray of a person who has just drowned, the x-ray will look absolutely normal. So the x-ray findings will usually lag the severity of the near drowning experience by a day or two before the pneumonitis sets in. Treatment is you got to stabilize the C-spine. Anybody they pull from the water, that's the first thing you do is stabilize the C-spine. And then maintain airway by either an OPA, an oropharyngeal airway, or intubation. Oropharyngeal airway and bagging them, or a endotracheal tube. This is the thing that you should always remember. You'll hear it throughout your career. You're not dead till you're wanted dead. So remember that hypothermia is the cause of PEA. That's one of the H's and P's. So you cannot stop the code until you warm them up to room temperature. If they're still dead, then you can stop the code. Otherwise, you have to proceed. You're not dead until you're warm again. Let's take a break. You look miserable. So, LP.
Yeah, it's
Yeah, let's turn it down. Probably open the doors. I don't think anybody's outside.
Hi, that's a first.
That's good. Yeah, I feel you. I had to just walk out.
So,
That's all I have left.
Thank you.
I don't need
Pretzels.
Do you see something where I live? It like really hurts. It's like there, like a split or something, and it hurts.
I had that.
It's like right there.
I don't see
Putting chapstick
anything.
on it, it hurts so bad.
The corner of mine hurts. Like, I think that mine tend to.
Putting on too much stuff.
No, it like really hurts.
It's like what kind of thing?
Like a split. Ah, it hurts. It's not real. It's not real.
I'm gonna go ask him real fast, but I have a patient follow-up this Friday.
Oh, me too.
Do you know how, like, you just go in and grab a laptop?
When?
Just bring your
I
laptop.
haven't decided.
I used a laptop that was there. I can't remember.
It's like,
Yeah,
it's already gonna
you
be
could just I'm sure we'll have to do so now.
whichever one's left.
Yeah, it's not that voice.
You've helped do the whole
Or the
thing.
show the Friday releases like on the 31st.
That'd be horrible.
I'm wondering, like, do we, I guess what I'm confused about is when we
Like one day
practiced it, we haven't done any, like with the follow-up, we haven't done any follow-up physical, anything really. Talk to me, like, how are you still feeling? You feeling better? Good. I mean,
Yeah, I
guess
don't
I-
really know what to do.
yeah.
He works that day.
Should we go ask him?
But I'll be done for the day.
You wanna do that right now?
Ashton, are you going to this weekend, so you can?
No.
Your family is not like
Sorry.
No, I never played. You go to every
Oh, the thing of the pepper, she asked what smell was it. Is that pepper? I think that everybody like the box of food or something, all the mix. Alex, check your email. Check your email. Cause you don't check your phone. Yeah.
My lady in public. I know. I'm so excited. No. So I think it's just. No, I was gonna say is reassurance. My dentist always calls me when I need to go, and I know this is it. I keep like ignoring them. Because I hate the dentist so much. And it's like my only.
I have to remind myself. That was unexpected.